participants joining from different time zones of the world. I welcome you all to this webinar on navigating ethical issues in large community-based vaccine field trials. This is the second webinar in a series of 4 webinars on ethics in clinical research being organized jointly by the National Biopharma Mission and the United States National Institutes of Health Clinical Center. These webinar series are aimed at capacity building in ethics in clinical research in India under the broad umbrella of the Indo-US Vaccine Action Program, a bilateral collaboration between the Department of Biotechnology, Government of India, and the Department of Bioethics, US National Institutes of Health Clinical Center. Biotech Consortium India Limited is the partner assisting in organizing these webinars, providing support to the National Biopharma Mission. We are pleased to have with us an esteemed panel of speakers who are policymakers, ethicists, and researchers, and a huge audience who are joining us through the webinar platform and also through YouTube live streaming. So before we start with the proceedings of the webinar, I would like to state that to be connected with the audience who we cannot see, we have some audience poll questions which we will post in between the sessions during the course of the webinar, and I urge all the participants to please respond so that we feel connected and that you are with us. So before delaying any further, I would like to introduce our chair and moderator for this webinar, Dr. Christine Grady, Head, Department of Bioethics, National Institutes of Health Clinical Center, United States. She is a nurse bioethicist, and a principal investigator with research focused primarily on ethics in clinical research. Dr. Grady, over to you to steer the discussions.
Thank you very much, Dr. Shantita. I am Christine Grady. I'm the head of the Department of Bioethics at the National Institutes of Health Clinical Center in the United States, as was just said. And I want to thank the National Biopharma Mission for collaborating with us on this very important webinar series. I especially want to thank Raidar Lee and Shreya Malik for all of their tireless efforts behind the scenes, making sure that these webinars got put together. Today, as you can see from this slide, we're going to be talking about navigating ethical issues in large community-based vaccine field trials. And we have an illustrious panel of speakers who will join us in this discussion. I'm going to say just a few words about vaccines before I introduce the speakers. And then as you heard, we're going to hopefully have time to answer some of the questions that you sent in before. So as I think everybody knows, vaccines are, as Dr. Stanley Plotkin, sort of father of vaccines, says, one of the brightest chapters in the history of science is the impact of vaccines on human longevity and health. And there are a number of different vaccines that we know and we have taken and we use in health that have reduced morbidity and mortality around the world. And there's many more than I put on this slide. And of course, we're in the process of still trying to find some for diseases that plague us, like malaria and HIV, and now COVID-19. Vaccines have been widely used in many places around the world, but they have to go through a very stepwise process to get to the point where we can be delivering them to people around the world to reduce morbidity and mortality. And as everybody probably knows, the stepwise process includes basic research, then preclinical research, and then a series of clinical tests. Phase 1, which is small and looks at safety and toxicity. Phase 2, a little bit larger, that looks at safety and immunogenicity. And then phase 3, which is large field trials, safety and efficacy. And that's the focus of our discussion today. These large field trials are done in a variety of places around the world. They're usually randomized, placebo-controlled, double-blinded, and done in a multiple number of sites at the same time in the community. And vaccine field trials are different than trials, for example, of treatments for a number of very important reasons. The participants in the trials are healthy subjects, healthy people who might be at risk of infection or disease, but are not sick at the moment that they volunteer. Vaccine field trials engage a large number of participants in the thousands or tens of thousands. I mentioned already they're usually randomized placebo control. There is some risk to the individuals of being in the trial, although one of the goals is to make sure that the safety of vaccines is very high. And individuals might benefit from being in the trial, but the larger benefit is benefit to the community or to society in controlling the disease. And most field trials have some long-term follow-up. The goals of vaccine development are pretty straightforward. We want to find safe, effective, easy to deliver, available, and affordable vaccines so that they will be used by the public. And this process is a very complicated and important process, and that's the one we're going to talk about today. So to address these issues, we have 4 speakers. I'm going to introduce them now, and they will in turn speak to you for about 15 minutes each. So addressing ethical issues in vaccine field trials in India during the COVID-19 pandemic is Dr. Rolly Mathur, who's the scientist and head of ICMR Bioethics Unit. To address planning and implementing community-based vaccine field trials is Dr. Elizabeth Higgs, who is at the National Institute of Allergy and Infectious Diseases in the United States. To discuss navigating ethical issues during the conduct of community-based vaccine trials, Dr. Sanjay Juvekar, who is the officer in charge, the VRHR at Chem Hospital Research Center in Pune. And addressing community involvement and risk communication, Mr. Bartholomew Wilson, who is the social mobilization, communication, and community engagement manager for the PREVAIL studies in Liberia. So with that, I'm going to turn it back to Dr. Sanjita. Or to Rolly, to Dr. Rolly Mathur, sorry.
Thank you very much, Dr. Christine Grady, for the introduction. And I thank the National Biopharma Mission for this opportunity to speak during this webinar and on a very important topic and a very dear topic. COVID pandemic, as we all know, has created panic among masses in a manner that people are rushing to seek protection at all costs with the belief that vaccine, even though experimental, would be their life savior. This calls for extra efforts in upholding the highest standards of ethics when research is being conducted. But that is easier said than done, since there are huge gaps and challenges, misconceptions around vaccines, and a lot of background preparation is needed in preparing for large community trials. ICMR has been on the forefront of building ethical guidance for the country and takes pride in keeping the country updated in the emerging knowledge in keeping with the national requirements as well as the global standards. There have been a series of guidelines documents that were prepared, revised, and updated from time to time, available on our website. And in fact, since our US colleagues are here, I wanted to point out that when the Belmont report was published in 1979, around the same time, ICMR had brought out the first policy statement in the year 1980, which talks about ethics committees and protecting vulnerable people, clinical trials, discusses ethics, informed consent issues, as well as publication ethics. In the 2017 National Ethical Guidelines, there is a full chapter which talks about ethics preparedness for research during humanitarian emergencies and disasters. And it tells how expedited or unscheduled meetings could be held, how electronic quorums could be recorded, and it discusses the need to protect the sensitivities involved in dealing with people who are affected, fairness and selection of the participants, and look at ways in minimizing the risks when dealing with communities. It also incorporates the WHO NURI framework, which is for emergency use of unregistered interventions. And I'd like to inform you that now, under the new drugs and clinical trial rules since 2019 March, the ICMR ethical guidelines are now mandated to be followed for all biomedical and health research in India. I also feel proud to share with you the fact that India was one of the very first countries to prepare a national guidelines for ethics committees for reviewing COVID-19 research during the COVID-19 pandemic, which was prepared very quickly under the guidance of our National Ethics Committee. The document has been downloaded not only in India, but even by more than 30 countries from our website. And the purpose was to facilitate review and conduct of not only new COVID-related research, but also about non-COVID research and ongoing other researchers during the lockdown situation through unscheduled meetings and using innovative approaches. However, when we look at the global media coverage today, it highlights the ongoing debate and heightened public concerns related to clinical trials. There is an unprecedented demand for speed and to fast track to deliver the promise of vaccine. I've come across the warp speed trial, which is being planned in the US and many other countries. Other trials have to be done. But on one hand, this is there, but on the other hand, it is so important to ensure rightful ethical pathways are followed without any compromises. Since there seem to be more questions than answers, there is all the more need to ensure best ethical practices and societal trust. Large field trials in communities are needed as they help to quantify the degree of protection that will be offered by the vaccine and to test it on the ground, despite the completion of the preclinical and safety studies, whether the vaccine would or would not really be effective in the populations or communities and masses. It is therefore important to consider these large trials, but then also to realize the importance how only good science can lead to good ethics. And therefore, while on one hand, we ensure clinical equipoise, we must think about using adaptive designs, innovative methods, maybe try out multiple approaches and learn from global experience in building our studies. And the bottom line is scientific rigor, adequate caution, data checks, and high degree of safety for creation of new knowledge. Field trials in communities therefore require much cautious approaches. It starts right from identification of the study sites, which fulfill the regulatory requirements, having adequate infrastructure, facilities, training, experience, and capability of handling and generating high quality evidence. Since there is also very high geo-ethnic and cultural diversity in India, selection should not be just for the sake of convenience, but should be based on the infectious dynamics that is prevalent to deliver relevant outcomes. The ethics committees at participating sites should be duly trained and experienced to not only review, but also to guide and monitor the research. They must identify ways to engage with local communities and ensure a good informed consent process. Often, research proposals do not address ethical concerns because the responsibility of identifying these is often left to the judgment of the ethics committees, and that is what we see in many trials when they come to us, that ethical approval will be taken is all the consideration often researchers take. So many matters can be resolved actually if researchers are more proactive and address the ethics issues in the protocol right at the inception. In fact, every stakeholder involved, whether it is the researcher, sponsor, institution, ethics committee, or regulator, everybody has a responsibility of upholding the implementation of the ethical guidelines in letter and spirit. A study that is poorly prepared, conducted at sites which are unprepared, or investigators who are untrained, lacking in communication, engagement skills, sponsors with financial targets to meet, and institutions and ethics committees that are not independent in their decision making pose serious threat to the quality of research as well as public trust. So we are all aware of the principles of ethics, but what is important is to see how these principles of autonomy, beneficence, non-maleficence, and justice, which look theoretical, have to be translated in practice. So the first and foremost thing is about participants and the communities. They come first and they need respect. There's a challenge related to therapeutic misconception when we are talking about vaccines, because even though experimental vaccines, randomization, placebo, these things don't really make sense to a lot of people. They may not understand, as no one would actually like to believe that he or she may not get the actual vaccine, but a placebo or just the fact that the vaccine may not work. So to explain this, one needs to devote time, engage for clear understanding, imparting information in simplified manner, ways, maybe using audiovisual tools, culturally appropriate methodologies to allow uncoerced or unbiased voluntary decision making. In dealing with communities, besides the community permissions or permission from gatekeepers or village leaders or community leaders, individual consent is extremely essential. The ICMR guidelines have discussed how electronic methods can be used for consenting in the changing times, the importance of assessing decisional capacity, and realizing that there may be an inability to distinguish between relief, care, and research, especially at this time. And therefore, decisions are difficult. And sometimes the decisions may have to be taken in consultation of family. So it should not be limited to merely signing a long consent form of 20 pages in a language and manner that is not understood. So these are things that we have to take care. Vaccine trials offer no direct benefits to individuals. They do offer benefits that are mostly societal to the scientific advancement. And however, the risks are directly to the healthy volunteers who have been administered a vaccine of unknown efficacy. And therefore, how does one justify the benefit-risk ratio? There is no evidence beforehand to confirm if the experimental vaccine would be efficacious, or even if efficacious, as proved later, one may be in the control arm and may be deprived of a dose and would be advised to get vaccinated once the product is marketed. So how and what can researchers do more? How can they give more benefit? So it could just be, for example, by simply ensuring there are relevant facilities at the sites to provide better care, better engagement, communications, medical management, payments of compensation in case of any research-related injury or harm, having insurance policies in place, if there are any cost implications related to travel or other reimbursement that are needed, proper follow-up, adverse event management, referrals, and so on. There is a lot you could do. And community engagement is crucially important pillar for a community trial. And it's important to not only be sensitive, aware of the local requirements, but to build trust before initiating a field trial. And also to try to empower the community where we are doing the research. This involves effort to learn, identify requirements, meet with the local leaders and representatives continually. And ICMR guidelines say that this continuous, it has to be started before the trial and continued during and after, and right from inception. So all this is needed. They can actually be invited to EC meetings, or you could have community advisory boards, or you could have representatives as part of the study teams. And fair selection of participants or clusters or communities is also important. As an ethical requirement, communities that bear the burden should also be the one to reap the benefits. Preemptive planning may be needed in dealing with discrimination or stigma that may be associated with participation in a vaccine trial. Benefit sharing and post-trial access should be built into the protocol from the beginning. Access to be given to the communities who participated in the study once vaccine becomes available is one such approach. Now, vulnerable populations or persons or groups need more protection, and so many studies find it much easier to just exclude them, to not have the vulnerable persons in the study at all. This actually means that we may be denying an opportunity to these people to benefit, even when the initial safety studies have been done before the field trials are done. So blanket exclusion is thus no longer acceptable. There should be scientific reasons to justify their inclusion or inclusion in the trial. For example, it may be easy to exclude vulnerable persons such as children or pregnant women But one must also think ahead that when the product becomes available, how will these groups derive the benefit? This needs meticulous planning, close oversight, needing additional oversight, time, and effort to put safeguards into place and not to deny the opportunity of prospective benefits. So, this is one consideration that has to be done. So, coming to the end, actually, these are some of the tools from ICMR that may be useful. The first one being the common forms and checklists that have been prepared by ICMR in collaboration with PHSTI. These are exhaustive forms, can be downloaded from our website and adopted by any institution involved in biomedical health research. They will help the researchers complete the documentation through checklists, suggest the ethical issues and the regulatory requirements that may be required for that study, and facilitate robust review by an ethics committee. The second one is the common review of multi-center research. This is a suggestion that has come in the 2017 guideline, and it can save a lot of time and effort and improve coordination between a site wherever a multi-site study is planned. The main designated ethics committee could do a main review, but then the local ethics committees are still responsible to review the local site-specific issues such as informed consent forms, language translations, study implementation, monitoring, guidance at the local level. The third thing that you see is about emergency review SOPs that have been prepared. Many ethics committees in India did not have SOPs for conducting an emergency review or unscheduled meeting or reviewing through an online or virtual meeting basis. So these SOPs can be adopted by any ethics committee, and they could begin streamlining their ethics committee review during the lockdown situation. These are available on our website, and we really welcome the feedback so as to revise these based on your experiences. And in the end, I would like to just say that recognizing the importance of collaboration to conduct robust scientific research using innovative designs, ensuring oversight to maintain social value, safety of communities, and continued engagement for building trust and quality outcomes is the need of the hour. Thank you all for joining us today. Thank you very much.
Thank you very much. That was wonderful. Now I believe there's a polling question that we're going to have.
Yes, Dr. Grady. So you see the first audience poll question. Please respond. You have 15 seconds. All the audience, I urge them to respond. During an emergency, experimental vaccine can be given to communities after phase 1 trial to save population from infection. Please select true, false, not sure. So we see the poll results. Where 25% said true, 63% said false, and 13% are not sure. The correct answer is false. Thank you, audience.
Thank you.
Over to you, Dr. Grady, for the next session.
Yes. So we'll turn to Dr. Higgs to talk about planning and implementing community-based field vaccine trials.
Sorry, Dr. Higgs is having problems here.
Sharing.
So, am I going to show my screen, Chris?
Yes.
Okay.
Did you get an invitation to share your screen? Philip should have sent you one.
Okay. Are you
There you
seeing
go.
my screen now?
Yes,
Okay,
now
great.
we can.
Okay. Good evening, good afternoon, and good morning. I am going to focus on aspects of, see if I can get rid of this, on planning the success to planning for success, the integration of social mobilization, communication, and community engagement into your field-based trials. I'm going to highlight several important features of the planning process. Most importantly, recognizing the importance of social mobilization, communication, and community engagement to the success of the trial, the need to integrate it into the overall planning of the trial from the outset, understanding with great clarity who your stakeholders are and what the principles are that underpin your social mobilization, communication, community engagement strategy, and then talk a little bit about the strategic planning process, the organization of the team, some of the materials that are useful, and underscore the importance of the IRB for those materials. I'm going to draw heavily on the NIH Liberian experience in implementing the first Ebola vaccine trial in Liberia during the 2014 Ebola outbreak and the subsequent trials that we have done since then. The NIH was asked at the height of the Ebola vaccine outbreak in Liberia to come and initiate a program to accelerate the development of vaccines and therapeutics in Liberia. At that point in time, the country's liberties were severely restricted. There were quarantines, lockdowns, dead bodies were left in the street. There was tremendous distrust by the community of all authorities. The country had undergone 3 civil wars, and that was a situation in which we were planning to launch a vaccine study. There were rumors about that Ebola wasn't real. It was a prevalent belief in the community, something that we've seen also initially with COVID, that there were fake Ebola vaccines. And so at that point in time, during our very first conversation, we went over, prepared to talk about science. And during the very first meeting, the lead for the Liberian scientist, Dr. Emmett Dennis, the then Liberian president of the University of Liberia, told us that there was, one issue that was going to determine our success or failure, that we could do everything right, but if we didn't get this one issue right, that we would fail, and that was social mob. And we didn't really understand what he meant by social mobilization, and we came to understand that it was very similar to good participatory practices, and there was an emphasis on this robust need for advocacy, community engagement, communications, and social mobilization, which we shorthand SMC. And we discussed the importance of leveraging the community response structures. The communities themselves have begun to organize. They recognize the importance of the interventions. They didn't trust other people. And so this was an integral part of our planning and ultimately led to our success. Sorry, I'm having a hard time with my screen here. So as previous speaker identified and Dr. Grady articulated, and there's several aspects to successful vaccine trial. First off, it's really important that it aligns with country goals, and it has to be a recognition that the community wants to contribute to an overall health goal. And it has to be led by a relatively trusted entity, usually by the host country government. And it needs to be scientifically rigorous and often with clinical endpoints. And this fourth element is this integration of the community and good participatory practices and social mobilization and communication. So it's important in the planning of a trial to not just focus on the protocol, but all aspects of how you're going to conduct the trial. And you'll see here, this is a schematic of our planning structure, our organization, our partnership with Liberia for each of the groups at the bottom, we call them pillars, there was a US lead and a Liberian lead. And that includes, you can see everything from site development to the protocol to data management to ethics. And you'll see here we have social mobilization and communication. And it's just important that that is an integral part of the team, that the SMC representatives participate in protocol team calls, the development of the protocol, that they bring back to the protocol community feedback, that they help the protocol team understand the community beliefs, the participant beliefs, and the stakeholder beliefs. So while you're conducting, as I mentioned, we didn't really understand what social mobilization was, and as we begin to dialogue and communicate, we understood that good participatory practices, which were developed by the HIV community around HIV prevention and vaccine trials in 2011, were really very similar to the principles of community engagement that were held in Liberia. And those fundamental principles include respect, mutual understanding, integrity, transparency, accountability, and community and stakeholder autonomy. After the Ebola outbreak, the WHO led a group in developing good participatory practices for epidemic pathogens, and that document, I think, is quite relevant for our current COVID crisis. Is when community liberties are restricted, the social mobilization and community engagement process is that much more difficult, as we just heard from Dr. Rowley. So the second element here, which is really important, is to understand who your stakeholders are, who you are engaging. And the most important stakeholder is obviously the trial participant, and really important through the consent process and otherwise to engage the trial participants. Secondly, it's the community. The trial participant exists in the context of a community, which is family, friends, schools, colleagues, peers, local religious leaders, traditional leaders, youth groups, women's groups, faith-based leaders, local healthcare service providers. And the next group out is kind of the broader stakeholders, which it can be local NGOs, local policymakers, media, medical professionals, universities, foundations, funders. And then, of course, the national stakeholders are also important. ICMR, the emergency management system, the national scientists, the parliamentarians of the government, the Congress, regulatory bodies, ethical review committees, funders. And then, on this outer ring, we have the global stakeholders, the international NGOs, the trial sponsors. That would be people like WHO or MSF and international organizations. And what was very interesting during the Ebola crisis is that most of the dialogue about what was going to be acceptable to communities and trial participants took place on this outer ring rather than at the community level. It was this green ring where there was a lot of discussion about what communities would accept, what trial designs were ethical, whether communities would understand placebos or not, whether trial participants could understand therapeutic misconception. All of that was taking place away from the community, and a good SMC program will take that dialogue right down to the trial participant and the community level. So equally important to the success of your SMC efforts is the planning that goes on for the team. It's really important for there to be a strategic planning process that articulates exactly what your vision is, what your mission is, what your values are, what your objectives are as a team, and then how you're going to make it happen. And Mr. Bartholomew B. Wilson will be talking a lot about how we implemented our strategic plan. The focus here is to really emphasize the need to have one. you'll see here that, our broad vision was really to support the success of the clinical research program. But our mission, which was more achievable, more focused, to facilitate the understanding, trust, and support from participants, communities, authorities, traditional and societal institutions for the research that we were undertaking. We really wanted to create a partnership with the community. It's important that the team understand and share values. How are you going to do this? What's important to you as a team? And it's so important to have integrity. And really, in the context of a field trial, you want to ensure that you've got accurate information. This means that you have to have scientific involvement. The biomedical scientists need to be an integral part of the SMC process. Our motto was, listen first, and that was out of respect. Understanding that we didn't understand was the beginning of the dialogue, that it was important for us to first listen. For example, the word research in Liberia for the community often conveyed a sense of involving animals. So research was done on animals. Trials were done on animals. And so just by simply listening, we understood in order for us to communicate accurately, we couldn't use the word trials and research. We needed to use the word study. We want to be inclusive, and we want to listen to everybody. And of course, service-driven. We had to understand that our primary mission was to support the research. So our goals were aligned with these, with our mission, to ensure that all of our activities were strategically aligned with the current research needs. So there's a life cycle to a trial. There's the planning, there's the initiation, there's the implementation, and then of course there's the reporting back of the results. And the SMC activities will be planned in what we call for the roadmap, but they really need to be current with what is going on in the research process at a particular time in the research cycle. Of course, we wanted to facilitate accurate knowledge among all of our stakeholders, and learning how to communicate that was important. We needed a strong advocacy platform, particularly in the context of an outbreak or a pandemic like we are now, with so much mistrust. That advocacy platform for some of the mid circles and outer circles is equally important as the dialogue with the communities. And we want to make sure we always had bidirectional communication, with ongoing communication. And as Bartholomew will explain, we did that in a variety of ways, including assigning each participant what we call a participant tracker, somebody that they could reach out to. And of course, the goal was to develop trust and positive attitudes among the community members and our stakeholders. So we organized ourselves into 4 pillars: and advocacy, community engagement, communication, and monitoring and evaluation. Each of these pillars had a role to play in our planning process for the roadmap that Bartholomew will tell you a little bit more about. We've gotten a little bit more sophisticated in our monitoring and evaluation over time. In the most recent large Ebola outbreak in the Democratic Republic of Congo, we've been integrating real-time social analytics so that we take information that's available through public channels, media, social media, radio, TV, newsprint, and distill it down weekly so that we can capture the rumors and attitudes that the community has about the ongoing research.
Libby, you have about 1 more minute, just so you know.
Okay. So it's important for the team to understand that the SMC materials have to go to the IRB and ethics review because they're considered recruitment. And I'll just skip up to the consent process for field trials. We developed something that included a group-informed consent using a flip book. you can see in each person sitting in these chairs would have a flip book, and the individual would present each, a pictorial graphic representation of the consent, and allow individuals in this group setting to ask questions. And from our experience, this created a lot more dialogue, which actually made the consent process go much more quickly. This was used by the WHO in the recent outbreak, allowing them to vaccinate up to 10,000 people per week. So these are just some pictures of exemplar flipbook for you. And in summary, SMC is a key element of success to any trial and has to be integrated into all aspects of the trial. It has to be continuous throughout the study. And to hear more about how we did this when Bartholomew gives this talk. Thank you.
Thank you very much. Now, I believe there are more polling questions now.
That's right. Can we have the first poll question? What is not a critical determinant of the success of your field vaccination trial? Rigorous trial design, robust SMC following GPP, global respect for your study, alignment with country health boards. We see the audience response. The third option, global respect for your study, is the correct option. We have another poll question. Social mobilization, community engagement, and communication do not need integration into the study team. True or false? False is the correct answer. They do need integration. Dr. Grady, over to you now.
Thank you very much. Everybody got that one right. So now we're going to turn to Dr. Sanjay, who's going to talk about navigating issues in the conduct of trials. Thank you very much.
Is my screen visible to everybody?
No, they were, and then they disappeared again.
Now? Is that okay?
No, we can't see them.
No? It is saying show, yes. Again, I'm doing it again.
No, we can see your screen.
Yeah, okay. So let me go to the next. Thank you very much.
Yeah, there you go. Perfect.
Thank you very much. Yeah, thank you very much, Chair, Christine, Shreya, Sanchita, Dilip. This has been great, and thank you very much for this opportunity. And I hope this will be a little interesting session for everybody. What I'm going to do is give an example of what we do at the KM Hospital Research Center, the Vadu Rural Health Program. And this is going to be something what we do exactly, which is based on what Dr. Rolly Mathur explained us all. So this is going to tell us how we work in a large-scale community-based study, whether it is a vaccine trial or beyond vaccine trial. We cover about 170,000 population for DSS. And by the virtue of DSS, we get a platform where we could do large-scale studies. but we go beyond that to about 10,000 population. But whenever we go to the community, what is more important is we go with a specific mission, and our mission is to provide evidence-based, sustainable, rational healthcare solutions for the rural population using globally relevant, community-based ethical research. The mission statement itself includes quite a lot of what Dr. Oli Mathur explained us. In order to do, we need to understand that a lot of factors interplay in between themselves when we are talking about conducting community-based studies. And it begins with the perception of the people of understanding research and research priorities. Sometimes it may be, may not be. What drives that? And it is all these socioeconomic conditions and the educational status of the population that drives their perception. It's nothing rocket science. And then is benefit to the community at large. Now, when we say community at large, people sometimes are concerned about what is true for me. What are the risks to my child when my child participates? So risks and benefits for individual participation is equally important. And when we go to the community, it is always important that we keep in mind the opinions of the peers and the social leaders, because the risk and benefit, however the researcher or the investigator explains, the study participants are going to trust more their own peers or their social leaders. So we need to keep them engaged as well. And then what about the service providers regularly who provide service to this population? So the role of public and private sector who provide the usual services is very important. If we stay away from them, the studies are less likely to be working. But when it comes to doing all this, the first thing we've been listening in the last two presentations is community sensitization. We have to engage the community completely. We have to have the community service activities as well to engage the community. It is not that we only talk about engaging the community at the time of the vaccine trial or the study which you are proposing. It should be right in the beginning, even if you're not doing the study, involving them. And that time, if you have a support of a hospital which is based in the rural areas, for example, for us, we have a 30-bed secondary care hospital. We provide routine services. Blood donation is one drive which helps us to go closer to the community. There are other activities like the health checkup camps, the ophthalmology camps. Now, these are the things which keep you engaged closer to the community and tells us what the community is actually interested in. In addition, we also have nowadays the dissemination of our activities through the social media. It plays a larger role, but we also know that in-person and these community services help us better. When it comes to community sensitization, the meetings at large is very important. Nowadays, because of COVID, we are all onto the use of technology, but even before that, what was more important is talking to the community. And it's not just tell them what you are going to do. We have realized from our own experience, and I can tell you my own personal experience, right in 2007, we started doing the first vaccine trial, and this trial was on meningitis vaccine. Now, this is something very different. This trial, we told the community very truthfully that the study, even if it is successful, the vaccine comes into the market, it may not be of use to your own population, your own children, your own relatives at this moment, because meningitis itself is a primary importance is to the sub-Saharan Africa. And then we told them that, would you like to still participate when you know that this is not going to be of great use to you? It may or may not be, but definitely it is going to be of use to somebody in the African continent. And to our surprise, when we truthfully told them at all the community meetings, we had absolute zero refusal and 100% compliance in our first ever vaccine trial in the rural areas. So that is the strength of community sensitization. Over the period, we realized that one-to-one communication or one-to-one in the sense, for each study we go to them separately is not enough. What is more important is we should have a team. And that's where the Community Engagement Committee came into existence about 10 years ago at our place, where a representation from the institute as well as the community. And these are community leaders. Some are not community leaders, but the representation from the women who really play an important role as members to when you talk about the family decisions. So all these things we thought, and we invited as many as possible from within the community. 1/3 of the population of the members are usually the representation of the institute. Rest all are from the community. The community conducts, this committee conducts regular meeting throughout the year, irrespective of whether there is a trial or not. So we should not wait for a study to come to us and then we go to the community. It spearheads the community engagement activities throughout. It plans dissemination, addresses issues raised by community time to time, and it should be really approachable to the members of every community in your area. That is the crux of it. And it then helps to go into the next steps of administration of informed consent. Now, this is an example I've just given because we have been talking about community. But when it comes to consent, we all know that for any regulatory trial, it is the medical doctor who would be sitting in the premises and giving that consent and not in the community. So there are some challenges. For example, complex nature of the research project needs to be explained. Dr. Roli Mathur will explain that it is so important that you go use a simplified language. But is that always possible? How do you do it? It should be done with better translation. And better translation enough that illiteracy or the poor education in this community also has to be taken into consideration. When you talk about other challenges, it's the heavy documents. You have 10, 20 pages document. And the more the regulatory trial, the pharma industry trial, you decide the document size goes on increasing. How feasible it is? How do you do this? Once you have a document, you can't say that I will just cut short and present only 10 points. No, you have to do everything. But what is important is while administering that large consent, you have to emphasize on the key risks and benefits to the population, and more so the risk. Explain the risks at a better thing. Don't focus on benefits so much so that you should talk about the risk, so that a true informed consent is given by the participants. Regulatory requirement of AV. Initially, we thought that might be a challenge, but when we realized that the AV consenting itself tells us that people are very happy because they know that this is truthfulness. As long as we assure them of confidentiality of their data, they're happy about it. And decision making is always in the community. When we have male-dominated community, when we have family-dominated community, it's not one person taking lead. Although, however, we would like that woman is independent to take the decision of her child, probably she may not be. So we have to respect all those. We are not there as social transformers or activists there. We have to play the role of a true researcher and keep respecting how the community behaves and explain the community about. When it comes to informed consent in pediatric population, it is even more difficult, especially when the decision makers are some other people than the people who are with the child in front of you for your consent. And that's where we have to be very careful. We have to explain everything. We have to give good time. All the GCP compliance, if you do properly, it will easily possible for you to do large-scale community-based trials. While doing so, there are a lot of questions that come, and I'm just highlighting 6 questions which usually people come up with. For example, how much of blood? How many times the blood would be taken? What are the side effects of your vaccines, if any? Are there any medical care provided if there is anything, if anything goes wrong, what we call AEs or SAEs? Can we visit a private provider instead of coming to you? This is very typical of Indian systems, may not be applicable everywhere, but at least wherever the private sector is dominating, it will be there. Will there be reimbursement for travel and medical expenses if we go to our doctors? Very surprisingly, initially when we did our first trial, this question hasn't come, but now we are getting what is the result of a similar studies conducted elsewhere. And we are very happy that these questions are coming because it is showing that we are educating our population time to time. They know that we have to inform them if anything happens anywhere in the world on the similar trials, and we have to keep them informed. So this is what is very useful. But then how do we achieve this? For us in KEM, we have the local community representation in our team itself, and that has helped us a lot. Almost 65% of our team is from the rural populations. It helps us to understand the local social, cultural context when we go to them. It improves the rapport, that's very common, but it improves adherence by the participants. It is also convenience for the field visits, because if you are, we know that people are from the same area, they know the houses, they know the people, they know the roads, everything. And there are some other benefits like, the building empowerment of the people themselves. We are there for 15 years. When we started, there were hardly 2 or 3 people working from within the community with us. But when we went there with a focus, now we have 65% of our team from that area. That is what is very important. Now, when it comes to training these people who are from the rural areas, especially in our area, I can give our example. It is very challenging to train them for every different trials, every study. So best thing is the good SOPs creation, and that has helped us a lot. Every individual villager who participates in our trial as a study person, we ensure that the person is trained very nicely, and that has helped us. Continuous monitoring, obvious, every trial needs that, and it really helps. Continuous training for once doesn't help. We need to keep on training our people again and again. That helps us. And in generation of quality data, if you want, retraining, training, and good documentation, as well as ethical standard maintaining is important. And if for that, we need to train again and again. This is how we have been doing. And for that, what has helped us, as I said a little while ago also, provision of standard of care in addition to the care that a study would usually give. So the access to the UIP, that's just something important. Usually, the sponsors may be reluctant. You give the study vaccine and let the people go to take their UIP wherever they want. We don't agree to that. We have to tell our sponsors, please, the participants cannot go from place to place for one vaccine here, the other vaccine, and in the same time duration. How do you manage? So UIP at the same time is very useful, and it has helped us a lot. We have found that this is very useful. When it comes to post-study, the access to the vaccine, this is definitely to be done, especially when there is a placebo-controlled studies. But then there are challenges, because we know by the time the results come out, it is going to be long. And it is also same time when it is a vaccine which is already licensed and you are conducting a study. What happens if there is eligibility of the participant who, for example, a rotavirus vaccine needs to be given in 6 to 8 weeks of age. And by the time the study is over and the child has not received the vaccine study, you need to do that. How do you do that? So those things have to be thought before you start the studies in these large-scale rural areas in Sweden. Provision of medical care for study participants. The laws are very clear. At least in India, we know that until such time the essay is found to be related to or unrelated to the study product, you need to give. The moment it is found to be unrelated, you need not give the study medical care. But what happens is, if you really want to build trust, if you know that this is a necessity and you are working in an area where it is already underprivileged, you need to give them easy access to the health. Familial care providers should be there. How do we do this? A good public and private sector involvement helps us. We have a network of private sector in our area. So all the private doctors in our area, from a rotavirus study example, I can tell you, when we went there initially, we were wondering how one or two of our person sitting at the hospital provides the safety care to all the people if the study is of 1,500 to 1,000 participants. There came the support of the private and public sector, because irrespective of whether we invite them or not, the people invariably go to the preferred healthcare providers, and that may be private or public. So keeping them informed, keep them in the network, and keeping them informed of what should be done, what do we need, what is the study about, helps us, and this has helped us a lot. Going one step ahead when it comes to management of serious adverse events, an on-call dedicated person at your facility helps. This person is not going to go to every individual. There are 6 SAEs. This person is going to go to 6 individual homes 20 kilometers away. What is important is this person is available to facilitate appropriate care to the people with the support of the network what we create. And we have done this in the past 15 years. We would have catered to at least 15 to 20,000 individuals during the follow-up. And all these people have been taken care at their preferred health facilities and not only to our place. This is what also helps. We should not insist on taking a particular healthcare, but the healthcare provider of their choice. That really helps. And hence we need the collaboration with the health system. That is very important. Now I've talked about people. I have a couple of more minutes. So I've talked about the community, the participants, and the private healthcare provider. Involving the other stakeholders, like engaging the public health system right in the beginning, has been proved to be very useful to us, especially because we have about 500,000 population for the vaccine trials participating in. We don't expect them to travel all the way to our place. What we have done is we have access to the government infrastructure for study activities. Our team goes there. We have study clinics within the government health facility, but that is possible because good stakeholder engagement. Therefore, when we refer any case, we don't need to refer them every time to KEM. If their preference of the participants is government health facility, we refer them. But they would take care of our people well when they know that there is a study ongoing and documentation of AE, SAEs is very important for the study. So they also provide us with the documentation at their place. It improves the trust and credibility within the community as well as with the health system. And that is how it has been helpful for us. Other considerations, if you talk about these are not mine. Everything is measured. It's not mine. But there are some of the things which I just wanted to tell you is like equal chance of study participation to all individuals, irrespective if you get a phone call from a community leader, oh, take my child in that study. You have to explain them that it may or may not be possible. It depends. Let your child come to the study clinic. We would see, our doctors would examine all those things. So it should not be that just because you are pressurized by the community, you involve that person in the study. So those things you have to explain the community very well that what does equality mean? What does equity mean? Also in giving an opportunity to participation. Assuring gender equality is also important and we all respect that. We had this classic example of COVID. We say that privacy has to be maintained, confidentiality has to be maintained. In COVID-19, we said that, okay, you are positive, you go to the public health system because there is a need for quarantine and all. But here we have to actually disclose the identity to the health system. But we know that this is going to happen, so we had that in the consent form itself. And if you tell them at the consent that even if we come to know, unlike our usual transfer, we have to disclose your name to the public health system, and we do that. And there was good cooperation. The study is ongoing, but the truthfulness helps us here. Look. Last slide. These are the points, 8 points we all need to remember. There are many more. I have given experience of only our site, the Vadu site, the KM hospital site. There may be more examples, more things to keep in mind, but these are how they, for example, strong community engagement and participation, ensuring informed consent, ensuring local community representation in the study team. This may or may not be possible for everyone, but if possible, please do that. That is really helpful. Rigorous and ongoing training of study members, especially if the study community is participating as study team members. You must ensure that they should be trained enough to differentiate between when they go there as a study team versus when they are in the community as their own people. That is what is important. Partnership with private and public sector proves very crucial. Provision of UIP vaccination to all study participants at our own cost is important than relying then on the government system and sending, just referring people there. Ensuring access to the healthcare and management of adverse events should be very meticulously done. It is not only for documentation, for safety of the individuals. That needs to be done very well, and we've been doing that. And last but not the least, the post-study access to the vaccine. Even for the COVID vaccine, now we are ongoing, the study is ongoing, we have told the sponsors, come what may, the moment it is there in the market, once you have licensure, we would like you to give us. We may purchase, but we want access to our population first. That's it from my side. Thank you very much for patient listening.
Thank you very much.
That's my team here, as I said.
Great. I believe we have one more polling question. Is that correct? Correct, Dr. Sanchita? Yep.
Yeah,
There we
two
go.
polling questions.
Two, sorry.
Yeah. Community Engagement Committee has representation from which of these? Research institution, community, none of the above, both first and second option.
Yep.
So both 1 and 2, actually, the last option is the correct answer, which most of the audience has got right. Next question. All the following are appropriate methods to ensure adherence during community-based studies except community sensitization, ensuring administration of informed consent, handsome compensation for study participation, or local community representation in the study team.
Wonderful.
Third option is the correct one. Dr. Brady, to you for the next presentation.
Thank you very much. Looks like everybody's learning some things. So our final speaker is Mr. Bartholomew Wilson, who will talk about community involvement and risk communication from personal experience. Thank you, Bartholomew.
Thank you. Good morning, good afternoon, and good evening to all. Can you all see my screen?
Yes, you can.
Yep.
It's not on the slideshow yet, though. There you go. Thank you.
Okay, thank you. All right, so I'll be talking about community involvement and risk communication, and basically I will look at why community engagement is important in clinical trials, when to engage research communities, and then we'll be looking at some lessons learned from the Prevail vaccine trials in Liberia. So maintaining public trust, first of all, public trust is the most valuable currency in research, in clinical research. And in order to be able to build and maintain that trust, it requires a high level of community engagement. And that is why the social mobilization and communication is the medium through which that trust building process is enhanced. Because social mobilization, which also includes community engagement, it provides the platform for local voices where people are able to express their fears and concerns about the research, to share their views, and most importantly, to be heard. Because in the midst of all of that, if communities feel like they're not being heard, then it is not a good thing, because then it derails the process of trust building. So you want to make sure that those concerns and those fears are addressed, and you are also taking their perspective into consideration. This is an indispensable component of GPP, as Dr. Hayes earlier on mentioned. But what is more important to all of this is the timing. When do you engage communities? Okay, sometimes people think that community engagement should happen when the protocol is being implemented, but community engagement is a process, it's not an event. And so you have to make sure that you engage communities during the study design, because this provides the opportunity for your study, to be improved, It also provides an opportunity for the instrument, including the messages and materials, to be locally acceptable, culturally sensitive, and accurate. Also, during study closure, you engage communities so that you can provide them the research findings and ensure that those findings are then used to inform healthcare delivery for the research communities. And as one of our speakers said, that's one of the benefits of research, where the findings are communicated back to the research community and they are used for policy decisions. So we'll look at the Preview example. In 2015, Preview started a project. First of all, Preview was established by the request of the Liberian government through the Minister of Health. And the US government responded to that request through the NIH by initiating the Preview project. So it's a partnership between the Liberian government through the Ministry of Health and the US government through the NIH. So before we initiated that vaccine trial, we have to look at some of the issues that existed at the time, the local context. First of all, we had civil liberties that were restricted because we have Ebola outbreak. There was an increase in social vulnerability. The society was disrupted. We had curfews and quarantine measures being imposed rather than, talking with community leaders and making sure that they had to say some of those measures were basically imposed on the population. And so there was an escalation of fear. You have huge confusion and distrust in the government officials as well as the healthcare delivery system. But on top of all of that, Liberia was a society that was basically research naive. Not many people knew about research in general. Not much studies or trials have been conducted prior to the Ebola outbreak. So this is the situation we had. And here on this picture, you will see this is a local media platform. So what you see on here is public perception about Ebola vaccine. And this is how the vaccine was communicated. The public perception regarding the vaccine was communicated at the time. So you see the image that the media was portraying about the vaccine. And this is before we started some of the social mobilization and communication activities, sorry. So to deal with all of that, a real social mobilization and communication strategy was developed. The objective was to use the existing community structures, identify social and cultural norms, and provide the opportunity for community to share their perspectives. At the end of the day, we wanted to build trust with research communities and establish a sustainable partnership that could create the awareness and facilitate the conduct of clinical trials in Liberia. And so our SMC strategy was built on 4 pillars. We have the advocacy, the community engagement, the communication, and the M&E component. So before we began the implementation of the protocol, the first thing that we did was community mapping. The essence of community mapping is to identify major stakeholders. So you have the formal authorities and you have the informal authorities. So these are people who serve as influencers, they serve as gatekeepers, but they could potentially they could become barriers if they are not engaged. So we identified those, and we were also able to identify cultural principles, social and traditional norms that were relevant to the success of the trials. We did this by conducting listening sessions and focus group discussion with small group meetings. Okay, we're able to access community knowledge, attitude, and practices, not in a formal way. Normally, it should be done, you conduct a knowledge and attitude practice, you do a KAP survey, which is a form of formative research and understand these things. But because we were in an emergency period, we didn't have the time to conduct that engagement through the formative research. We didn't have anthropologists in Liberia who could do this for us. So we had to do it ourselves, and we had to do it by leveraging the existing structures that were already in place from the Ebola response. So yes, we're able to identify potential barriers and facilitators, and we listened to community concerns people participating in the clinical trials. By doing this focus group discussion, this is an example of a focus group discussion going on, right in the community. You have some of our partners working with CDC, WHO, and you have the MOH also represented here. So these are some of the things that came out of these engagements. We had rumors about Ebola virus, being man-made. Others said the virus was brought to Africa. We heard rumors about the vaccine study is just, for financial gains. There were also perception and misconception regarding the research terminology. Dr. Hayes talked about it earlier on. One of the community meetings, we learned that trials is a word that have a negative connotation in our society. It is done on animals, and therefore it will be resisted by the research participants and the communities. So then the community suggested, the leader suggested to us, instead of using trials, we suggest you use the word study, which could be, understood and culturally appropriate for our society. So that's one of the benefits of doing those pre-engagements. Now, the next step was to develop our messages and materials. So we have different kind of message and material developed. And we use FAQs, flyers, we use posters, we use banners and jingles. But the most important thing is that these messages could only be developed with the community participation. Okay, so they drew up the FAQ. Those questions came from our community meetings. They came from our focus group discussions. And those questions, formulated the FAQs. The flyers came from the FAQs, the posters, they all came from the FAQs, and then we had to go back to the Ministry of Health to get the approval. And once we get the approval of the Ministry of Health, we do piloting, so we do pre-testing of those messages and materials to ensure that whatever we got from the community is reflected in the message that we develop. So community approval also was something that we took into consideration through the pre-testing. So here is an example of our recruitment materials that we use. You have the flyer, you have the poster, and you have the banner, they are here. And there I have also a jingle that I would like to play maybe for a minute so that people hear some of the ways in which we use music. Music is a form of communication in Liberia. The Liberian population is predominantly youth. The youthful population is large. And therefore, music is a way of communicating in Liberia. So we use this jingle, which is a music. I'll try to play it. I don't know if you hear it, but.
A little hard to hear, Bartholomew. That's better.
Hello, can you?
Yeah.
Could you hear my audio?
Yes, that was good.
Okay. Well, yeah, so that's how we use music to communicate. Sorry, yeah, that's how we use music to communicate the message. And then the next thing is once the protocol is approved and you need to start implementing the protocol, then we conduct advocacy with leaders. And these are leaders that were identified during the listening session and during the community mapping. So the essence is you want to get their support, political will, and to build support for clinical research among these stakeholders. We also build trust because once we engage them and we get the blessing, then we can now move on to actual community engagement activities. So in the community engagement activities, one of the most important things that we realize is that these activities have to be organized. These meetings have to be organized by community themselves. It's a form of, local ownership. It's a form of empowerment. Okay, so we try to provide study education, and we create community awareness through community engagement meetings, but the meetings are organized by the community themselves. They find the venue, they identify the time, and they set the agenda, and we go to the meeting, and it is basically bi-directional. So we engage research community through community-based platform, community meetings, and interpersonal communication. So we also use interpersonal communication because we recruited community mobilizers from the community who go from house to house, they go to the market, and they give people flyers, they sit with them, they explain the research, and they get questions and answers from those people that they engage. So here is an example of interpersonal communication going on with a small group. And this is our social mobilization coordinator, Joseph Boy Cooper, talking to the community. Also, we use the media to provide information, the print and electronic media. So the radio is listening to is one of the biggest platform of communication in Liberia. So we use the radio. And here is Dr. Fala. He's one of our principal investigators. And in the middle there, you see Ambassador Jui, and she's the cultural ambassador of Liberia. This is to say how important it is. The messenger is as important as the message. So when you have the rightful people providing the message, it makes it credible. It helps to build trust, and community trust in the research team. So we use the jingles and the drama. We conduct radio talk shows, we do press releases, and we do the mobile moving stage, which are all mediums of communication in Liberia. Lastly, of our 4 pillars, we have the monitoring evaluation, and we do monitor and evaluation to be able to understand the impact of our strategies on the research and the clinical trials. And just not to make any assumptions, we just want to make sure that whatever strategies we are using are making the necessary impact, and they are also representing what the community wants. Okay, so these monitor and evaluation activities involved media monitoring. We conducted surveys, we did focus group discussion, and we did individual interviews. So here is an example of a report from the media monitoring that was conducted by the Novera Group in Cadence. We were in partnership with them, so they did media monitoring of positive or negative messages regarding the preview and preview trials. Also, we try to understand the level of awareness in different communities. So up here, you see the level of awareness in Monrovia, which is an urban community, was basically mostly influenced by the radio, okay? Whereas when you come here to Lofa, which is a rural community, you see the level of awareness was influenced by community meeting and community leaders. Also, as part of the community empowerment, we made sure that community members were recruited to be part of the research team, not just as participants, but as part of the protocol implementation team. So they asked us to involve them because they thought that would be able to build trust, and community involvement will help to build trust in the research team. So the community leaders and the Ebola task force at the time identified and recruited participant trackers. And later we realized that these participant trackers play a very fundamental role in ensuring study retention. Okay, so they were following because they were recruited from the communities, they were known by the participants, they were trusted, so they ensured that participants adhered to the follow-up visit, and that's why we have over 98% retention in the vaccine trials. So when communities are not engaged, there are some things that could happen. First of all, they feel research upon, they don't see themselves as partner in the process. They feel used by the research team, and this help to create more suspicion and misconception about the clinical trials. There's a lack of trust in the research team, and the benefits to the community are not, clearly understood by the research community because they are not engaged, they are not involved. Okay. Also, there's a likelihood that the research findings are not translated into actions and changes that benefit the community. So it's very important to engage them right from the beginning, doing study implementation, and at the closure of the study to return results. So some of the things that we learned from the preview example is that engaging community doing study design and prior to protocol implementation help to promote trust within the research community. It also creates easy access to community entry, and it helps to, to clearly change the perception of the community regarding the research. Because when we started implementing the preview trial within 3 months, we're able to change community perception, the negative perception that you saw from the beginning. We're able to change that to positive, thinking. And that's why within 6 months, we already recruited 1,500 volunteers in the study. Therefore, researchers should be sensitive to local and cultural requirements for community engagement. Also, if we had the opportunity to do this again, we will make sure that formative research is conducted to inform clinical trials. Some kind of social and behavioral science research, either through focus group discussions or KAP or in-depth interviews. Because at the end of the day, these social science research findings will help to inform the clinical trial that you want to conduct. Of some of the cultural issues, some of the community concerns, the social norms that you need to be aware of that could potentially serve as barriers to the success of the research. So that would be one recommendation. And therefore, scientific standard must always work within culture and not against it. Okay, so this is one of our guiding principles, and we try to incorporate that in all of our preview studies. Even after the clinical trials, the other 9 preview studies that we're conducting right now, this is one of our guiding principles. Thank you.
Thank you very much. Wonderful. Wonderful speakers, all 4 of you. So I think I have a bunch of questions that were sent in by participants that I would like to ask you. But before I do that, I wanted to just see if any of you have questions for each other. And if you do, I'm happy to entertain them. If you don't, and you find you have one later, let me know. Does anyone have a question they want to ask of each other? Go ahead, Dr. Rowley.
Yeah. So the million-dollar question is that we understand, and our guidelines say that we have to do all this engagement, and we have heard of such elaborate ways of engaging. Now, how in the pandemic situation are we actually going to do so? Do you have an insight on that? Is what I would like to ask. Thank you.
Great question. Bartholomew or Libby, you want to answer that from your experience?
I can start and Libby can come in. Yeah. So I mean, it's difficult. It was a challenge for us because the whole idea was to start the study as fast as possible. We want to make use of the opportunity, but at the same time, we realized that without doing these things, it was going to serve as an impediment to the success of the study. So what we didn't do was to conduct the what you call the formative research from the beginning. But because we already had structures in place, and those structures basically came from the response, you already have the contact tracers that came from the community that were supporting the response. You also had case investigators, and you have the community-based organizations that were set up by the Ministry of Health. So what we did was to use those existing structures, work with them to identify, those community leaders, the formal and informal authorities, and the gatekeepers. Okay, so we leveraged the structures that were already in place and we engaged them. So the engagement at the time was an ongoing process. It was an ongoing process. And sometimes we have to come back, rethink, readapt, but yes, it was an ongoing process.
Great.
Yes, and all of those things are absolutely spot on. And one thing I think is really critical in the outbreak situation is to respect the local expertise. It was clear to the NIH team that the Liberians needed to lead in this process. And had we come in with external social scientists, they probably would have suggested ethnographic mapping. But we didn't really need ethnographic mapping because we had people like Bartholomew Wilson and Mosoko Fala who'd already been working with the communities, and because they had been working with the communities, they knew who the influencers were, who the formal leaders were, who the informal leaders were. And so that saved us a great deal of time. And in our current situation in the US, we're undergoing COVID vaccine trials, and there's a large effort underway to engage the relevant communities, particularly communities that are disproportionately affected by the COVID outbreak, and that is going, I think, pretty well. But still, in some of our vaccine trials, we've had to close, enrollment to certain populations so that we could expand enrollment of other populations. We did the same thing in Liberia. The men volunteered early and the women didn't. So we had to close the trial for some period of time to men so that we could enroll women so that they could be represented in the research results. And the same process is ongoing now in the US with at least some of our trials so that we can enroll the appropriate populations who are disproportionately affected by SARS-CoV-2.
So I want to ask one of the questions that came in from the participants, and I'd love to hear Dr. Sanjay and Dr. Rowley's response to this. It sort of builds on your question that you just asked that Bartholomew and Libby answered. But basically, the question is more general. Does ethics hinder the development of vaccines and drugs, or does it slow it down, or how does it get in the way?
Rolly, would you like to add? I begin. Did I?
Okay, you can begin, then I'll add.
Okay. Person for the field. I think ethics is not hindrance. Never we found ethics to be hindrance. It is primarily how we researchers first understand ethics clearly. If we are very clear in our minds, we approach the community and explain. It's the way we explain and how truthfully we explain helps us. We, at least in our setup, we have never seen ethics to be a hindrance.
Great.
Its truthfulness is more than enough.
So I think that's a very important question, and it often comes up. Actually, I see it completely the other way around. Ethics is there to ethical approaches help build research, help ensure quality outcomes. Actually, a good ethics committee review can make the research very meaningful and applicable. And it can help to tune it to the needs and requirements of the people or the communities who are going to eventually benefit. The important thing is for the ethics committees to be helpful. Often we find that ethics committees are sitting on a pedestal and they are blocking or, So it is the communication between the researchers and the ethics committees that has to be built up so that the ethics committees actually guide research. They support the research initiative, help the researchers understand and improve their research. So in fact, a good ethics review will provide a societal and an equity lens to the research proposal. So therefore, it is important also that the ethics committees be competent, aware, and proactive in undertaking quality review. I think that is what is required to, bridge this gap. Thank you.
Great, thank you very much. I see that Dr. Rydar Lee has a question. Rydar?
Yes, I have a question to Dr. Sanjay. One question, and then let me see if I can share my camera. Here we go. And then I have a question also to Libby and Bartholomew. The first question, Dr. Sanjay, I was very intrigued by your example of the meningitis trial in India, where you asked the participants if they were willing to take part in the trial, not for the benefit of India, but for the benefit primarily of people in African countries. I don't think that has been documented before, that specifically. I think it would be interesting actually to have write it up with more details. And what I was wondering is what sense you had of their reasons for wanting to do this, and do you think it would be different if you had a trial that would be for the benefit of Europe, and different if you had a trial that would be of benefit to people in China? I mean, for example, China has a number of vaccine candidates for COVID-19, but they have no COVID-19 in China. They could reasonably say we would want to do that trial in India. Sort of reflections on that. And let me just also ask the question then to Libby and Bartholomew. That's my shorter question. You both mentioned the trackers that you used that were sort of identified as individuals that people could go to if they have concerns. Could you say a little bit more about the qualifications of what kind of people you used as trackers, specifically if you had any worries about whether they would give correct information to the participants in the trial when they were asked questions about trial design or concerns or other things that they have? Because again, this is basically just to hear more about it, because I think this is an area that has also been underexplored in the literature. So those were the two questions. Thank you.
Great.
Thank you, Dr. Ryder. That's a great question, and really a good question, and we need to understand it in very details. There's no straight answer to it, yes or no. There would be conditions, but if you ask whether a population, general population, when we go to them, would they have concerns if the study is going to benefit Europe or maybe more the developed nations and not these countries per se? Personally, knowing the Indian population, by the way, I'm an anthropologist by training and I've been working in India for the last 30 years, and knowing our population very well, I think it is the educational status, and the media plays a lot of role. If the media has told many things against a particular country right now in today's, for example, COVID, then probably that might have impacted the people whether to participate or not. But when we explain them the importance of humanity and why you should participate, it all depends of we are there for the last 40 years, almost 50 years now. Since 70s, we are working in that area. But although we started the clinical trial just about in 2007, but we've been working there. So it's the trust of the researcher. And if the community is assured that this is not going to harm their own community, but in turn will help some community, be it in Europe or in the UK, elsewhere, I think there would be positive. But yes, you're right, there may be concerns, but these concerns nowadays, and again, there is no evidence with me, but my fear is that the WhatsApp and the current day media will drive a little bit of or it will affect some of the decision making. Thank you.
Very interesting. Libby or Bartholomew, want to talk about trackers?
Take it, Bartholomew.
Yes. So the most important requirement for the participant trackers at the time was, one, they should be people that lived within the research community, and they should be people that are trusted, by their community leaders or the community members. Okay, those were the fundamental requirements. Yes, there were some there was a need for training, so we had to train them. We had to train them on the study protocol. We had to train them. We developed an SOP for tracking participants. We train and retrain them on those SOPs and make sure that they follow the standard operating procedures. But no, there were no issues as far as this study is concerned. There were no issues of them not following the SOP. The good thing about it is that the trackers are people who already also supported the response effort in the Ebola outbreak. Some of them were part of the Ebola task force, so they understand some of the principles of confidentiality. They understand the principles of participants' autonomy and things like that. So yeah, we trained them, but there was no educational level requirement. Say you should be maybe a college graduate. If that is what would be a concern, it wasn't a problem for us. Once they could, understand the research protocol, they understand the standard operating procedure, and they were well known in the communities and respected.
And Bartholomew, it's worth mentioning that they were selected by the community leaders. And it's an example of leveraging the outbreak response because contact tracing was already well established and accepted by the communities. And so using the word participant tracker might not translate to another cultural context because that might feel invasive. But in this context for this particular trial, that was understood as necessary as part of the infectious disease control process. Similarly, we had a call-in line for our participants to call us after their vaccination for reactogenicity or questions, and our phone line wasn't working. So the very first night, we just decided to start calling the participants, and I was doing some of the calling, and it was really appreciated. They really felt cared for, and I think the same sense that the team cared about their individual well-being that we were able to convey the biomedical team, we conveyed through the social mobilization team through the participant trackers. There was stigma associated with being vaccinated. We had individuals who were thrown out of their homes by their families because the prevalent belief was that you could get the Ebola infection from the Ebola vaccine. And so they would be able to reach out to the participant trackers or to the team. So it helped with the communication process. And as Bartholomew said, the purpose of the SMC team is to help ensure the research is successful, and particularly with clinical endpoint trials, field vaccine trials, making sure that you have follow-up with your participants is critical to the integrity, the scientific integrity of the trial. And so we had 98%, compliance with our follow-up, which is really fantastic. So it was all part of this integrated process of SMC into the whole design of the protocol and its conduct.
Great. So there's a question on this list from the participants that kind of builds on this discussion a little bit in the following way. The question was about, what do you do? What does the research team do or the researcher do if it feels like the community leaders are pressuring people to participate? Or how do you determine that somebody's making their own decision as opposed to being caught up in the community mobilization? Anybody want to address that? Or any experiences?
Okay, we have a lot of such experiences. There are a lot of pressures from the community leaders in particular for, it's mainly for participation. It's not the other way around. It's more for, saying that, okay, take my friend, my people who are working with us. Like currently we are conducting a vaccine trial for the COVID, and there are phone calls from everywhere, right? The day people realized that there is going to be a COVID vaccine trial, and I started getting phone calls every morning, evening, night. It was a nightmare to manage this. It's primarily the way you explain them why it is not possible to just take because you want to be a part of it. You have to explain them. If you are interested, if any one of your friends, everybody is interested, please ask them to approach the clinic. And it will be, with equal opportunities in mind. It's not just because you are an important personality in this community, we would be able to include you. It may not happen. Sometimes you may not be able to participate. It all depends. So please come to the clinic through through proper channel. And these are the things we have to manage. It was very difficult though. The only good thing for us was our experience, and the people in our area have been exposed to such instances before. This is not only the first time we are doing in emergency situation. We also work during the influenza H1N1 pandemic. We work in this area, and people wanted to participate. It was only diagnostic. There was no vaccine then. Thank you.
That's great.
I also think the individual informed consent process helps ensure that if somebody is pressured by their community to participate, when they get to a private session with somebody from the study team, they can fully understand that it's a voluntary experience, and they can decide not to participate, and that's a private decision. But I think our experience, at least in Liberia, was the opposite. There was a lot of opposition to participating in the vaccine trial, and my worry at the time was, the communities had to be part of the process in as much as the trial participant was. And so with those concentric circles in Liberia, the trial participant and community really meld into one. And I think it will be very specific to a context and to a culture, how you approach the community and what level of influence the community has or has not on the individual participant.
Yeah. Go ahead, Dr. Sanjay.
I just forgot to mention one more thing that helps here. For all the large-scale community-based clinical trials, we need to ensure that there is a spokesperson and not everybody speaks there. This really helps, especially during these pandemic cases, and when you have an emergency, you're starting a vaccine trial. Having a spokesperson who speaks to the people really helps here. It's just an addition.
Very good. So along with that, there's a question about, we are currently experiencing a pandemic, and, Ebola was another example of a very difficult time, and H1N1 as was described. The question here is it ethical to hasten vaccine development during an emergency pandemic? And how do we determine, or how do we assure, I guess, safety? Anybody want to tackle that? Libby, you want to tackle that one?
Sure. I think it's an imperative that the global community address the pandemic with research. That research is an integral part of our response. It's incumbent upon us to invest in identifying safe vaccines and therapeutics to help mitigate mortality and prevent mortality and mitigate the impact of the disease overall. And I think that the answer to safety comes with rigorous research design, that we have to design the studies not only to learn if they're effective, whether it's a therapeutic or a vaccine, but whether it's also safe. And this is critically important in the context of a pandemic, because a very small percentage of the vaccine reaction that can have a serious adverse impact on the individual, when you scale it, that's going to be a large number of individuals. So I think it's really important that we gather a lot of safety information on these vaccines. And the trials that are currently underway are quite large, as I'm sure everybody is aware, with sample sizes of 30,000 plus, and rigorous research has been done to look at the safety in phase 1 and these phase 2-3 vaccine studies. It doesn't mean that we won't have any adverse events or adverse effects from these vaccines, but between following the regular rules of science, which do not go away just because it's an outbreak or a pandemic, we should be able to produce safe, effective products.
I think every one of you in your presentations stressed rigor as an important part of the ethical requirements for studies. So this question, I think, is for you, Rolly. It's, can a vaccine approved in other countries be used without a phase 3 trial in India?
Actually, the question is still not for me, but it is for the
Okay.
regulator in the country, and that is the Central Drug Standards and Control Organization, the FDA version of India. And I'm quite sure that their officers are making the best efforts and looking at all ways within the regulatory frameworks. In fact, they're creating provisions to see how vaccines can come in our country. And there are special expert groups that are guiding them, and surely they will take the decisions in the best interest of the people. So that's all I can say about that.
Okay.
Yes.
Okay. Anybody else want to speak to that? No. Okay. I was going to ask a little bit. I know that Dr. Rowley showed some information about simplifying consent, and Dr. Higgs showed the flip books or a few pages from the flip books. And Dr. Sanjay talked about, the importance of consent being sort of specific to the group that you're talking to. And Bartholomew talked about, the engagement of the community in determining what was okay in terms of presenting information. So maybe somebody could speak a little bit more about, what works in terms of providing information to people so that they can understand it in the process of consent. Anything more you want to say about any of that? or what obstacles did you? Go ahead.
For us, if you talk, our experience has been that when you go to the community, you need to take more time explaining the community as a whole beforehand so that you prepare the community better. Explain them everything about the study which you are going to take, especially the risks, definitely more than the benefits. What happens is people, in order to get more attraction, try to talk more about the benefits. But I would always say, and that's what I do during training my own people, tell them more about the risks and how the risk mitigation would happen. If you explain that clearly, I think this takes care of it. That's very crucial, more than just telling them about the benefit.
And do you
I don't know whether this answers your question.
I wanted to ask if you have, so I think Libby or Bartholomew showed a picture of a group discussion using flip books and presentation of information, and then followed by individual consent discussion with each person who's interested. Is that a familiar method in India as well? This group discussion of information and using of flip books or music or some other?
Music and flipbox, I haven't used in our area. None of my scientists have used. But yes, discussion in group. It's not focus group discussion for vaccine trials per se, but group discussion and explaining the study participant information. We have the consent form, has the consent form and the information sheet. If you explain that in greater details, answer queries from the community very well in a large community. What happens in India is, like, there are some fixed days when villagers gather together. So during these days, if you take some time and explain everything in detail, there is very good response to the participation. That's what we see. Although we haven't used these tools which Wilson mentioned.
Yeah, and I would like to add a bit, which is there from the guidelines, and the guidelines have actually encouraged researchers to use various audio-visual tools and give time to discuss with the family and friends before arriving at a decision, and also to ensure that there's no coercion or nobody's influencing. And sometimes you may have to have other social scientists or other counselors who need to be built into the study rather than somebody, for example, like we know in the case of treating physicians not to do consenting where there could be an intimidation or coercion or pressure or by a leader to be involved. So these are certain things that are mentioned. And also one more thing is about test of understanding. So depending on the importance of the topic, the ethics committee must look at it and see whether there is a need for, to have a test of understanding where certain open-ended questions can be asked in order to ascertain that the person has understood. Because normally when you don't ask an open-ended question, you say you have understood, they will say we have understood. but you really don't know what they have understood. So it's important to ask them some questions back to make sure they have understood, they've comprehended.
Good.
I think that one of the things that was helpful to us is in our listening sessions, we developed frequently asked questions, and we kept adding to those. And so I think that allowed us to help train, the people who were doing the group informed consent. It helped us to train the participant trackers. It helped us to dialogue with the community. And, just excellent questions would be asked. When talking about Ebola, for example, the question was, it disproportionately, women who get Ebola, who are pregnant, get really sick. How come you're not vaccinating them? And so, excellent question. Well, and if Ebola came from, monkeys, why aren't you vaccinating the monkeys? Why are you vaccinating us? I mean, these are people who might not be able to read, but just because they are not literate does not mean they're not brilliant. And so generating those lists of questions, I think, and talking them through with the community, as Dr. Sanjay said, really helped by the time we got to the consent process. There was already a level of literacy, as Bartholomew says, with the concepts of what we were doing, why we were doing it, and allowed in the group consent process just embolden people who might be shy about asking questions. If the person next to them asks a question, they're more likely to ask a question as well.
Yeah, great. Okay. Anybody want to? I have a few closing comments, unless somebody else has anything else they want to add. Any other questions you have for each other? Or for me? Okay. Before I turn it back to the Dr. Sanjita, I want to just say there were a few things I think that came out loud and clear in this set of presentations. They were all excellent presentations. It seems like one message that's very clear to me is that science and ethics go hand in hand. You can't do one without the other. And that when you're trying to do when you're trying to conduct a vaccine trial anywhere, it's absolutely critical to understand the communities in which you're having the trial, the priorities of those communities, their understanding of science, their understanding of research, their willingness to participate, and to treat them always with respect and constant, transparent, honest communication about what's going on. I think one of the things, I think Bartholomew said it, which I think is one we should all keep with us as we go on to our other business, is that public trust is the most valuable commodity in research. I think you said that, Bartholomew, something like that. And it is true. I mean, without the trust of the public, research at any stage for any reason won't go well. And certainly in the world of vaccine research, we need public trust because it's the public that is going to benefit ultimately from the research that we do on vaccines. So with that, I will thank you again for your great presentations and turn it back to Dr. Sanjita.
Thank you, Chair, Dr. Grady, for steering the discussions, and thank you all the panelists for the engaging discussions during the 2-hour webinar. We are sure that the participants have gained significantly from the discussions. So some notes for the participants. Please fill in the feedback for the webinar at the close of this webinar, or to the email that you would be receiving tomorrow along with the certificate for participation in today's webinar. We would also like to project to you the details of the next webinar in the series, which is the webinar number 3, which will be on challenges in conducting human challenge studies, policy perspective from India and the United States, on the 22nd of October. Please register for the webinar on the website www.nbmworkshops.com. The video proceedings of today's webinar will also be available on the website. Before we close, may I request all the panelists and the chair to please switch on their videos for a group photograph.
I think we're all on.
So this is the way we do in the virtual meetings.
Yes.
Thank you, everyone.
Thank you.
Thank you so much.
Thank you. Thank you. Thank you so
Thank you.
much. And have a nice
Thank
day
you for the
ahead.
wonderful
And
session.
to all of you.
Thank you.
Thank you. Bye-bye.
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 Bye.
Take care.